Terry Mabrito, and she's going to be talking us through NAMI walks.
All right, everybody. Can everybody hear me? I can't
Yes.
see anybody.
Yes.
All right, there we go. I'm so glad to hear voices. I can't see everybody, of course, with everybody joining the call. It looks like we have, I think, 47 people so far joining us for our general meeting today. So we're so excited that you're here. It is time to ramp up for several things. And the first thing, of course, is our NAMI walk. And that walk is coming up virtually. Oh, wow. Hey, we have a special guest. Can you see, everyone? Can you see our special guest? You might have to come a little bit closer, NAMI Man. Wow, NAMI Man is here, and he's reminding us that it's time for the NAMI Walk, October 10th. And he's saying, hey, be a team captain, join a team, donate to support mental health for all. Wow, this is a great day to have our special guest NAMI Man pop in and help us kind of kick off our time to join a team. Get on that website, get on the website NAMI Walk San Antonio, and join us, and we'll see more of NAMI Man as we get closer to October 10th?
Yes.
Thank you, NAMI Man. All right, everybody. So again, we're so happy that you're here. If you haven't formed a team, please check it out. The most important thing is kind of our presence in the community. And this year, because it's virtual, we need you even more to get on that NAMI Walk San Antonio website. And then participate with us on social media. So yeah, go NAMI Man, go NAMI San Antonio. Okay, I think, let's see, do I need to give, I'll give Melanie the host screen back in a minute, I guess. So we want to also introduce our next special guest. I don't know, Greg, I don't know if you can compete with NAMI Man. I'm not really sure about that, but we're really so happy to have Greg Hansch with us. Of course, he's the executive director of NAMI Texas. He has been with NAMI Texas since 2012 and was formerly in a very important role, which was public policy director and coordinator. And so you may or may not know this, but Greg was honored a couple of years back at NAMI National as the policy guru of the year. So he knows his job and he knows the topic for today. He's a master social worker and he's a family member caring for a person at times with this that has serious mental illness. He also has a nonprofit and public management specialty from Rutgers University, and a bachelor degree in government and politics from the University of Maryland. And he's a NAMI Smarts trainer, and you're going to hear more about that today. And I learned something about Greg that I didn't know. So I know he's, you know, advocacy is his game, right? And so he loves to help people register to vote. He loves being outdoor. I kind of knew that because he has a bicycle usually, like in his screen hanging in his wall. So we knew that. I knew he loves, you know, podcasts and checking out blogs and things. But what I didn't know is that he likes to watch Dallas Cowboys. So, hey, if you're a Dallas Cowboys fan, you are, you know, you're in the same boat with Greg. So today's topic, of course, is advocacy, mental health policy. We have to get ready, not only for the walk, but for the next legislative session, and that is coming up fast. So Greg's going to help us think through how we can participate and be involved for this coming session. And I am going to, let's see, do I give the host back to you, Mel?
Sure. Greg, you want to You want to go ahead and share, Greg?
Yes, I'll go ahead and share.
Great.
Just give me 1 minute to get ready here. My phone's ringing in the background. Sorry about that.
Perfect. That's okay.
NAMI man was really cool, Terry. You're on mute.
You never know when some, green man is gonna like show up in your house. I don't know what to say about that.
Well, thank you all so much for having me today. I really appreciate this opportunity. It's always good to visit with NAMI San Antonio. You all are a wonderful group of people and a really strong affiliate. And I'm just so pleased that advocacy is such a key focus for NAMI San Antonio among all the other things that you're doing, including preparing for your upcoming walk. It's great and so appreciated that you work so hard on advocacy and that you have NAMI Smarts classes that are coming up soon. We have our work cut out for us in this upcoming legislative session. It's expected to be a session where the budget is tight and money will not be flowing as freely as it has in past sessions. But that doesn't mean that we don't have the opportunity to make a big impact this session. And as far as I'm concerned, mental health should be one of the core focuses for our legislature in the upcoming session. And that has a lot to do with the fact that COVID-19 has presented such a significant challenge to the mental health of Texans. And there is some recognition and understanding of that, certainly within our community and the mental health community. We know that COVID-19 has made a very significant impact on mental health, but we need to raise the profile of this issue among our leadership in the state so that they put in place the policies needed to address the mental health of Texans, both those resulting from COVID-19 as well as those that resulted from other causes. So with that introduction, I'm going to go ahead and advance into the presentation. Looking forward to taking any questions that y'all may have, and we'll make sure that there's time for those at the end. There's a lot of ground to cover in this presentation. So I'm going to move fairly quickly through the policy priorities of NAMI Texas. Just for a little bit of an introduction, I'll introduce NAMI Texas and myself. NAMI Texas is, of course, the state organization of NAMI. We have nearly 2,000 members, 27 local NAMI affiliates, including NAMI San Antonio. And we exist for the very same purpose that NAMI San Antonio and other affiliates exist for. We exist to improve the quality of life for individuals affected by mental illness, both peers and family members. And as for myself, Terry gave a really nice introduction. I appreciate it very much. I didn't put in my bio as far as preferences and sports teams. I didn't put that I'm a Lakers fan because I know my audience, but I will be watching the Lakers tonight, and I sorry to have to let you all in on that because I know you all are probably Spurs fans, but it is what it is. So I've been executive director of NAMI Texas since last year, but before then I worked for about 7 years with NAMI Texas exclusively on public policy issues. So I have a strong background on our content and subject matter today. I wanted to just give a few brief words of introduction about how NAMI Texas goes about establishing our policy priorities. We are a grassroots organization, so what that means is that our priorities are heavily informed by and influenced by the membership of NAMI Texas. So every 2 years, we survey the membership to get feedback on what the issues are that are affecting people affected by mental illness throughout the state. The first survey is open-ended to gather information on member needs and opinions. And then the second survey is a rating or ranking system on the potential priorities that were gathered from the first survey. We've completed both of those two surveys, and we're now moving into the phase where we're close to actually publishing the policy platform, and that's what the next slide shows. So this is our remaining timeline. By next week, we will have finalized the written content for the 2021-22 policy platform. So we're, the content is basically there. We're just making some finishing touches, and then soon after that, we'll have a public document. There will be a period of time where the policy platform is being graphically designed, so to speak, so that we can present a polished product to the legislature. We encourage the affiliates to establish their own policy priorities, and some affiliates will sort of just by default adopt the policy priorities of NAMI Texas. Some will identify, more localized or specific issues on their platforms, but the platform is available publicly, and it's available for use by anyone or any organization that could benefit from using it. We'll make some revisions and edits after the graphic design of the platform, and then at the NAMI Texas annual conference, that's typically when we're publicly unveiling the platform and providing printed copies, that sort of thing. And the conference is scheduled for November 6th and 7th, actually in San Antonio. That said, the status of the conference is a little bit up in the air because of COVID-19. So it's not a sure thing that it will be held in person this year, but we'll have more details to come about what the conference or in a conference-like event might look like, either in person or virtually. Hopefully in the next week or two, we'll have some more information about that. So let's get into what the platform for 2021-22 is starting to look like. So the first policy category of 7 different categories is the capacity of the mental health system to address the full range of needs, cultivating a mental health workforce for the 21st century, and building out a continuum of care around the traditional system of care, so that people get what they need along the way as they progress through the mental health system. So we know that Texas does not have the capacity to meet the full range of the needs. The supply of mental health services does not meet the demand. And that has to do with, factors including the incredible population growth of Texas, with Texas being one of the fastest growing states, one of the most urbanized states in the nation. We don't have enough mental health professionals. We don't have enough mental health services to meet the growing need. And then COVID-19 is another, factor contributing to shortfalls in mental health system capacity. The stats show that 45% of adults report that their mental health has worsened during the COVID-19 pandemic. That's an incredible statistic, and we can expect that our mental health system is being strained by that reality and will be strained by it in the days to come. We're going to be feeling the mental health impact of COVID-19 for a long time. So, when you look at the impact of the capacity shortfall and the workforce shortage in our system, it includes that people end up unnecessarily in the criminal justice system. People end up living on the street. People end up in the emergency room or hospitalized. And we don't just have to accept that reality. We can bolster the system and the continuum of care so that people get the right care at the right time. So that's the the problem and the opportunity that we have in front of us. Looking at some policy recommendations to address these issues, Texas should focus on increasing funding for community-based outpatient mental health programs. A lot of people are on wait lists. A lot of people are on lower levels of care than the one that they're clinically recommended for. And that's because the system doesn't have the resources that it needs to facilitate access to the right level of care at the right time. So we think Texas should continue addressing gaps identified in the statewide behavioral health strategic plan. And those gaps include things like access to appropriate and timely mental health services, prevention and early intervention services, the utilization of peer services. We know the value of peer services. So while we are entering a tight budget climate, and it's going to be hard for advocates to articulate why funding should be increased when, you know, sales tax revenue is down, and franchise tax revenue, you know, other different important funding sources, oil and gas tax, you know, the revenues for our state are a real concern. When we know, you know, not only is the status quo not acceptable when it comes to funding for mental health services, but we actually need a bold investment to meet the growing demand for services. We just have to make the case that there are gaps that need to be addressed. The second item here is continuing the investment in state hospital system redesign and reconstruction. And this is an issue that advocates in San Antonio are quite familiar with, knowing that, you know, San Antonio State Hospital is in need of ongoing effort and attention to make it a modern mental health facility that meets the growing demand for inpatient care in the South Texas region and across the state. To date, over $200 million has been appropriated to make improvements to San Antonio State Hospital, let alone, you know, the hundreds of millions in other dollars that have been appropriated for Austin State Hospital improvements and Rusk State Hospital, and even Kerrville, also near San Antonio, would fit the category of hospitals that have been getting a lot of attention and investment. What's needed in the upcoming legislative session is about $152 million to finish the job and make the necessary improvements to San Antonio State Hospital. So without that investment, people will continue to wait in jail for access to services. People will continue to be boarded in emergency rooms. We need that investment. We also need investment in private psychiatric facilities as well, because the state hospital system is not a one-size-fits-all model for Texas. We also need investment in support groups and education classes for families, peers, and providers. And we know the value of these services well at NAMI because this is what we provide. These services help to meet needs in the continuum of care. They can be offered as early intervention services. They can be offered as services for people coming out of the hospital. They can be offered as services for family members who are looking for resources and insights and tools about how they can best facilitate the recovery of their loved ones. Some NAMI services are currently state funded, and there may not be folks who know that, but there are folks who also may be aware of that. NAMI Texas does have state funding to offer trainings for connection, recovery support group, and the peer-to-peer training. And that, you know, investment is really paying off. We've been able to train hundreds of people with that state funding, but it's not enough, and the funding doesn't go directly to the affiliates. We want funding that goes straight to the affiliates so that they can offer these, you know, not just peer programs, but also family programs in their communities. We also, you know, along similar lines, we need funding, increased funding for other types of peer services and other types of family support services, such as peer support specialists, which is a Medicaid reimbursable service, but the Medicaid reimbursement rate is far too low. And then family partner services also play an important role in our mental health system. And because of the important role that they play, we think that those services should be Medicaid reimbursable or should be receiving some other form of state funding. And lastly, you know, this topic on the screen around telehealth services has really, you know, bubbled to the surface during COVID-19. Telehealth services can be incredibly impactful, and there is strong evidence to support their efficacy. There's strong evidence to show that people are more likely to show up to their appointments if it's a telehealth service as opposed to an in-person service. And that's not to say that telemental health services are the one-size-fits-all solution, that they're a panacea for mental health services. I think it's all too easy to assume that these services can just help everyone who needs assistance, but there are, of course, a lot of mental health services that do need to be delivered in person. But there is a great opportunity to get more people into telehealth, especially for people who have transportation barriers or they're living in rural areas. Telehealth can it can facilitate their recovery in ways that I think we're even just starting to learn about. So the state has recognized this and has made telehealth services a priority during COVID-19, creating certain flexibilities that allow for telehealth services to be expanded and offered at parity with in-person services. Those flexibilities need to be made permanent. And also, we need to recognize that not everyone has the opportunity to utilize telehealth services because they don't have reliable internet access. So Texas should focus heavily on expanding rural broadband access across the state so that more people can tap into telehealth services. Next area are crisis services and suicide prevention services. And we are, of course, in not only Suicide Prevention Month, but we are at towards the beginning of Suicide Prevention Week, and Thursday is World Suicide Prevention Day. So this is an especially pertinent topic. The suicide rate in Texas has increased significantly over the last 20 years, 35% suicide rate increase. And with COVID-19 and the economic downturn occurring, we may lose hundreds of additional lives to suicide if we don't put the right policies in place. So we have opportunities to address these challenges, challenges including that healthcare professionals and educators don't always necessarily have the tools needed to identify suicide risk and make appropriate interventions. Law enforcement is our de facto response to mental health crisis in many communities, and it's good that law enforcement has trainings and they have resources to address suicide. But they shouldn't be our go-to one-size-fits-all solution. We have to remember that mental health crises are healthcare issues and should be treated as such. So to the extent that we can integrate healthcare professionals into crisis interventions, we should be doing that. And that's what part of our policy platform will speak to. We should be expanding access to crisis services, or as you might refer to them, alternatives to hospitalization, alternatives to incarceration. We also need to remember that trauma is a significant factor that influences quality of life for our great first responders. Law enforcement professionals, people who work in the mental health system, people who are providing services to people who are affected by COVID-19. We need to be accounting for those traumatic experiences. And then we also have improvements that can be made to the emergency detention system for people who are at risk of harm to themselves or others. So let's get into some more specifics about these issues. NAMI Texas would support requiring some form of suicide prevention training as part of educator licensure for people who work in the school system and health professionals. One might assume that health professionals are already required to receive suicide prevention training, but that's not necessarily the case, even though they're working on the front lines for people who are a suicide risk or who are experiencing mental health crises. So we should definitely be requiring, as part of licensure, suicide prevention training for these professionals. We also need to remember that if a person's access to lethal means to move forward with a suicide attempt, if a person's access to that is restricted, then they are far less likely to complete that suicide attempt. So if we can limit or restrict access to lethal means, even if for just a short period of time, and sort of get people through that acute mental health crisis, then their life is far less likely to be lost. We know from evidence in other states that tools like safe storage programs for firearms and extreme risk protective orders can and do save lives. And the lives that they are most likely to save are the lives of people who are a risk of attempting a suicide. So we've advocated for this in several past legislative sessions, and we'll continue to do that. Texas needs to have a tool that family members can utilize when they recognize that their loved one is a risk of harm to themselves or others and has access to a firearm. Family members should be able to petition to have that person's access to the firearm temporarily restricted. I was speaking on this earlier, but we should be utilizing healthcare professionals in crisis response a whole lot more. And there's a great program in Dallas that utilizes healthcare professionals, like sort of integrated teams where you have social workers and paramedics and police officers all working on the same team, and that allows for a multi-pronged approach to mental health crises rather than just throwing law enforcement into the situation, regardless of what trainings those law enforcement officers might have already attained. So we need to be promoting the use of evidence-based tools like these, where the program in Dallas has been extremely effective and has resulted in less emergency room episodes, less hospitalizations, less incarcerations. So we should be replicating models like those across the state of Texas. And we have a recommendation here about how that can potentially be done using an existing grant program. And then also we have to recognize that crisis mental health services are not as available as they should be. We don't have enough crisis respite programs. We don't have enough crisis stabilization programs where, if a person is experiencing a mental health crisis and is at risk of being incarcerated or being brought to the emergency room, we can do better than that. We can bring them to a place where the crisis can be stabilized and the situation can be de-escalated. Those programs are evidence-based and work really well. I was talking earlier about facilitating access to mental health services for first responders. It's sort of absurd that in our insurance code, post-traumatic stress disorder isn't identified as a serious mental illness when we know in the mental health community how debilitating it can be. And it can affect people from different backgrounds, whether they're a first responder or a veteran or a survivor of domestic abuse. Post-traumatic stress disorder can severely impact a person's quality of life. So it should be categorized as such in the insurance code. Senator Menendez from San Antonio has consistently advocated for that change to be made, and we'll continue working with his office to try to move that forward in the upcoming legislative session. We need funding for mental health programs to serve first responders. We need to ensure that first responders receive mental health crisis and suicide prevention training. We also need improvements to emergency detention processes. And this is where a law enforcement officer recognizes that a person is a risk of harm to themselves or others and can bring the person to a mental health treatment facility. Currently only doctors can file for mental health warrants to be issued. We should expand that ability to other types of healthcare professionals. We also need to give physicians the ability to exercise emergency holds so that if a person presents in a healthcare facility and is a risk of harm to themselves or others, we're not just letting them go because law enforcement officers aren't on the scene and physicians don't have the ability to, utilize their training and utilize their licensure to facilitate that person's access to care. This bill would, on the second bullet point, grant physicians the ability to exercise emergency holds. That bill was passed by the legislature in 2015, but was unfortunately vetoed. We'd like to see that that issue reopened and re-examined because it makes a lot of sense for getting people access to the right care. And then the emergency detention warrant period should be expanded from 48 to 72 hours because 48 hours isn't always enough for a crisis to be stabilized and for an evaluation to be done. Although, an evaluation should happen as early as possible in the emergency detention period. We don't want people to be put under unnecessary orders for protective custody. If we can just push the emergency detention time frame out a little bit from 48 to 72 hours, that may actually allow more crises to stabilize and less people to end up in longer term involuntary mental health commitments. We advocated for this bill in the last legislative session. Other opportunities to improve crisis services and suicide prevention efforts in Texas include expanding state capacity for crisis hotlines and support lines. As we mentioned, there's been increased demand for mental health services resulting from COVID-19. The state has established a mental health support line, and that line should be made permanent. We're going to be living through and experiencing the impact of COVID-19 for probably a long time, and we need to ensure that there is access to specialized crisis support for the population of people who are impacted by COVID-19. And we also should be utilizing peer services. When there's a crisis hotline, there should always be a peer available answering calls at that crisis hotline because of a peer's unique ability to relate to people who are potentially experiencing mental health crisis or who are just in distress and who need someone to talk to. And then Texas should address the issue of mental health information disclosures. We in NAMI know all too well that family members can be a valuable support system for an individual impacted by mental illness, but they're all too often cut off from being involved in the care of their loved ones. They're cut off from being provided relevant treatment-related information. We should be facilitating family members' access to information that could help them facilitate the recovery of their loved one. We worked with State Representative Steve Allison from Alamo Heights in the last legislative session to advance a bill that would have addressed this issue, and we hope that Representative Allison will again file that bill if he's in the House again next session. It was a good bill, and it would address these issues around mental health information disclosures, including cases where a person is a risk of harm to self or others. We should be permitting the disclosure of information to anyone who has the ability to mitigate the risk of the situation, not just to certain people, but to anyone who can mitigate risk. Third problem statement that I'd like to speak to is around early intervention, children's mental health, et cetera. So the issues here are around the fact that treatment is often delayed between the onset and a person's actual access to care. Average delay between symptom onset and treatment is 11 years. We should not accept that. That is not an acceptable status quo. We should be closing that gap because the sooner a person gets access to care, the better their outcomes are going to be. There shouldn't be any delay in symptom onset and access to treatment, if at all possible, but 11 years is far too long. We also know that a lot of family members don't have the information or tools that they need to support their child, and we have programs like NAMI Basics that can address that issue, and we need the state to buy into the value that programs like NAMI Basics and Ending the Silence can offer. We need to treat serious emotional disturbances as such. These are serious issues. And we need insurance to cover treatment for serious emotional disturbance. We need more first episode psychosis care. We need more special education services. And we need to focus on certain populations like children in the foster care system and young people at colleges and universities, people who have been impacted by trauma and interpersonal violence. So around mental health education for students and family members, we know that NAMI Basics empowers family members and equips family members with information that can help them support the recovery and well-being of their children impacted by mental health conditions. Why shouldn't these programs be state funded? Why shouldn't we be getting the support from the state of Texas that we need, because we're providing a valuable service to Texas within NAMI through our Ending the Silence workshops, NAMI Basics, and these programs supplement the traditional mental health system. They bolster the continuum of care, and they need to be recognized for doing so. And then insurance coverage, for children experiencing mental health conditions needs to be improved. Texas has a law that requires that insurance plans cover serious mental illness, which is a set of diagnoses that are most often applied to adults with mental health conditions. Why not provide coverage for diagnoses that most often impact children with mental health conditions? If adults are getting that coverage, why shouldn't children be getting that coverage? We've advocated for legislation that would have addressed this issue, and will continue to do so in the upcoming legislative session. Special ed services are really important for children with disabilities. Texas has not always supported special education services in the way that those services need to be supported. Over half of students experiencing a serious emotional disturbance nationwide drop out of school. And we know through past reporting and policy investigations that a lot of children are denied access to necessary special education services. Texas should be doing a much better job funding these services. Regarding children in the foster care system, this is a population that often falls through the cracks, that often ends up bouncing from placement to placement, or ends up in the psychiatric hospital system just because that's the only place that the state can think or can find to put them. We need to be funding programs that can prevent children from ending up in the foster care system in the first place. That includes programs like NAMI Basics, like substance use disorder treatment for both parents and children and adolescents. We need access to residential treatment services to prevent parents from having to relinquish custody of their children to the state. There are some really great opportunities to improve what we do in the foster care system as it relates to mental health. In the higher education system, we know that half of mental health conditions emerge before the age of 14, 75% before the age of 24. College is an especially stressful time for a lot of people. College is often where the onset of mental illness occurs. And our colleges are often not equipped to really address this issue. And, students are having to pay significant amounts of money out of pocket for mental health services at their campus mental health center, or they're on wait lists for services. That is not okay. We need to be closing the gap again between onset and a person receiving access to care. So there's a lot we can do in the higher education system, and we'll support, any bill that will help college students access mental health care. And then the next issue here is around access to care for first episode psychosis programs. And you all have a first episode psychosis program at the Center for Healthcare Services in San Antonio. But across the state, only 20% of the needed capacity for first episode psychosis programs is available. And because of that, people experiencing a first episode of psychosis who are usually under the age of 30, as young as 15, those individuals are often dropping out of school. They're ending up in the criminal justice system. They're ending up homeless. They're ending up unemployed. And we know what works. We know what will keep them from experiencing those negative outcomes, and it's coordinated specialty care. We need to expand access to this evidence-based best practice service for first episode psychosis. And we have advocated for that. And either the state should invest its own money in coordinated specialty care instead of relying solely on federal money. And the state of Texas should require insurance companies to provide coverage for coordinated specialty care, like the state of Illinois does. It works, and it's a good investment for insurance companies to be covering that care, because it means that they'll have to cover a lot less care related to long-term disability in the years to come. Other early intervention opportunities include preventing and treating trauma and interpersonal violence. We should continue the implementation of trauma-informed care practices in all systems whose participants are at a higher risk of having experienced trauma. Foster care system, psychiatric hospitals. There are a lot of places where we should be focusing on implementing trauma-informed care and practices. We should be preventing trauma of interpersonal violence by promoting healthy relationships in the K through 12 school curriculum and in other community settings. And victims and survivors of interpersonal violence should have access to counseling and other support services. The next problem statement or issue area is around insurance and medication issues. This is a really key policy priority issue area for NAMI Texas. We should not just accept that hundreds of thousands of Texans are uninsured and have mental health conditions or substance use disorders. If a person is insured, they're more than 50% more likely to get access to mental health or substance use disorder care. It is quite simply common sense for Texas to be doing everything it can to be facilitating access to health insurance for people who currently don't have it. Texas should join the growing group of states who have accepted federal Medicaid expansion dollars. It's the right thing to do for Texans with mental health conditions and substance use disorders. Texas should not just accept that short-term, limited duration health plans are the right solution for Texans looking for a health insurance solution. Short-term, limited duration health plans are often very limited in what they cover. They're inadequate. They have a lot of restrictions in place that block access to mental health care. And Texas should at the very least ensure that people who are purchasing these plans know what they're getting into, know that down the road, if they need care for their mental health, their insurance plan may not actually help, do much in the way of facilitating access to it. Texas should recognize that mental health medications are often a very important component of a treatment plan. Texas should be addressing treatment limitations that inhibit access to mental health care. And Texas should equip the primary care system to better address mental health. And we'll get into each of these topics. First off, on Medicaid and CHIP, Texas should accept federal funding to open up Medicaid eligibility to low-wage adults. These are adults who are in the coverage gap, who are uninsured, and because of that, they often have a really hard time accessing care. And Texas should fully fund Medicaid and CHIP because by kicking the can down the road and doing IOUs for Medicaid and CHIP, that often causes Texas to have to do cost-saving measures in Medicaid, which will sometimes block access to necessary care, cause services to be put on restrictive, tiers and formularies that mean that a person is limited in being able to access those services. We can, by fully funding Medicaid and CHIP, we reduce the risk of cost containment measures being put in place. And then I spoke already on insurance coverage for short-term health plans. Those plans should be limited in their duration. Renewals should be limited. They're really not a long-term fix for Texans. It might be a short bridge or gap to a more sustainable insurance solution. But a person just purchasing a short-term plan over and over again, it doesn't work, because eventually they're going to end up needing, more intensive services that are more costly, and their short-term plan just isn't going to cover those services. And then we all pay the cost for a person whose insurance plan doesn't cover what they need, because they end up in emergency care and other costly treatment settings. And there should be more disclosures around the potential costs to ensure better health coverage is provided to all Texans. Around medication access issues, all too often insurance plans are covering a medication in 1 year, and then the next year, a person stays in the same health plan, but the rug is swept out from under their feet because the medication is no longer on the formulary. There's a prior authorization that is now required for the medication. The medication is placed on a higher cost sharing tier for the patient, and they're no longer able to afford it. Insurance companies should not be allowed to switch people off of medications that are working for the person and facilitating their recovery and keeping them out of expensive treatment settings. We've made this a big priority. The bill passed the House last session and didn't make it through the Senate, but we already know that it will be refiled, and we'll work hard to move it all the way through. Prior authorization processes will often limit access to prescribed medications. Prescribers should have the ability to indicate if a prior auth is going to inhibit access to a medication and by inhibiting access, it will cause harm to the patient. Those prescribers should be able to say upfront, this prior auth is going to harm the patient, therefore, and they failed on medications before, therefore they need access to the medication that I'm prescribing as I'm writing it on the prescription. And that should suffice to satisfy the prior authorization requirement. We're working on a bill that would address that issue. And similarly, in the commercial insurance world, health plans should not be requiring individuals with serious and persistent mental illness to fail on a medication, a specific medication first, before they get access to the medication that their prescriber knows is best for them. The prescriber should be able to say, this is the right medication for the person. They have a serious and persistent mental illness. They need access to this specific medication at this specific time. And then we need policies that will level the playing field for mental health benefits as they relate to other health benefits. Oftentimes, mental health benefits are treated differently than medical and surgical benefits. This is a discriminatory practice that health insurance plans will often utilize, and it results in people with mental health conditions being denied by their insurance company for medically necessary mental health services, and that is not okay. We shouldn't just accept that. So there's a lot of good work being done already to figure out where Texas needs to go when it comes to ensuring mental health parity and ensuring that the playing field is level. There's a mental health parity work group that I'm the chair of. It's housed at HHSC, our state health agency, and we have some good recommendations that will facilitate mental health parity in our state. Compliance tools, health plans should be required to prove that they're in compliance with parity and submit information to the state that indicates their compliance. We should have parity complaints processes that are user-friendly, that aren't burdensome for patients or providers to utilize. Oftentimes a complaint gets filed and then it's just kind of lost in the shuffle, and it never actually reaches a resolution that works well for the person who is in need of care. And a lot of the time, the reason that parity protections aren't currently working is that people don't know that they have those parity protections in the first place. If you are a Texan with a mental health condition, you should know that your insurance company is legally prohibited from discriminating against you. And if you believe that your insurance company is discriminating against you for having a mental health condition, you have rights, you have recourse, you can file a complaint. The state insurance agency can investigate that complaint. They can pursue regulatory action against the insurance company. Not enough people, including individuals with mental health conditions and family members and providers, know that those protections are in place. We should also be better utilizing the primary care system. The primary care system is generally not equipped to be addressing mental health in a meaningful way, even though that's where a mental health concern often presents or is often identified. Up to half of mental health conditions present within the primary care system. So a patient goes to see the family doctor for high blood pressure or something, or diabetes. Somewhere along the way, the doctor might say, I think this person might have anxiety, or I think this person might have depression, and I'm not equipped to be addressing that. I don't have the training, I don't have the time to, get this person access to whatever services they need, whether it's medication or counseling or case management and a host of other services. The best that the primary care provider can do is often just say, I recommend that you go talk to a mental health professional. We need to integrate mental health services into the primary care system so that it's all available right there within the family practice, within the primary care practice. And we can be doing that through the collaborative care model, which is an evidence-based, team-based approach to addressing mental health in the primary care system. Universal access to the collaborative care model in our state could save more than 1,000 lives per year that would be lost to suicide. This is a no-brainer. We should, if we can save those lives, we should. We can do that by reimbursing by reimbursing primary care practices for utilizing the collaborative care model. This is an opportunity to transform our healthcare system in a way that would leverage what we have in the primary care system to address mental health in a far more significant way than it ever has. I think we know all too well within our network that the criminal justice system is a place that a lot of individuals with mental illness end up. And this is not the right setting for individuals with mental health conditions. Mental illness is a public health issue. It's not a criminal justice issue. And it is an absolute crisis that the criminal justice system is in a lot of ways our de facto approach to addressing mental health. This is where people are often ending up, and it's to the detriment of the individual and to the family, to the community, and to the taxpayer that the criminal justice system is one of our primary strategies for addressing mental health. It's not okay, and we just shouldn't just accept that status quo. 40% of prisoners and jail inmates have experienced mental illness. There are consequences to this in terms of the physical well-being of these inmates and the psychological well-being of these inmates. It's extremely expensive for the taxpayer to be incarcerating these individuals who will often cycle through the system. They'll be incarcerated, and then down the road, they're back in the community, but they don't get what they need there. So they're back in the hands of law enforcement. They're back in the crisis mental health system. And they're back in front of a judge who said, didn't I, just see you 6 months ago? Didn't that incarceration interrupt this revolving door? No, that doesn't work. We need diversionary practices in place to keep people out of the criminal justice system and facilitate long-term recovery. As we speak, hundreds of Texans are waiting in jail for access to mental health services. This is a profound abuse of people's human rights, and it's inefficient and ineffective for society and for these individuals' well-being. Also, we know that substance use disorder is often also treated in the criminal justice system, and the public health crisis around substance use disorder, including opioid deaths, is one of the defining public health crises of our time. And capital punishment for individuals with serious and persistent mental illness is just not okay. So let's get into some of these specific topics. People who are involved in the criminal justice system are generally not having the opportunity to work with someone who has been through a similar experience. And that's a huge missed opportunity. When a person has a mental health condition and they've been through the criminal justice system, they pick up insights and tools along the way that can be shared with others. And this is the very philosophy of peer services. We don't have enough peer support services in the criminal justice system and in the reentry system as people are coming out of jails and prisons. They should have access to peer support services. And then also another opportunity for our state is limiting the use of solitary confinement, which is very detrimental to people's psychological well-being. You have people with mental illness who are put into solitary confinement as a form of punishment, and that only makes their symptoms of mental illness worse. And then you have people who are, generally doing okay in the criminal justice system. They're not, experiencing a mental health crisis, but they do end up in solitary confinement, and that causes new mental health issues to show up. So solitary confinement is detrimental to mental well-being, and we should be limiting the use of it as much as possible. And we know what some alternatives to solitary confinement look like. We should be replicating those alternatives across the criminal justice system. All too often, individuals who enter the criminal justice system lose access to the medication that they were on before they entered the criminal justice system. This is really silly. If a medication was working well for a person, then they should continue to get access to it. And, we need to hold our jails and prisons accountable for not taking people off of medications that are working. So NAMI Texas has a bill in the works that would require jails to identify and document the medications that a person was on prior to entering jail. And the bill would also require jails to continue people on the same medications unless they have a legitimate medical reason for not continuing people on those same medications. And by doing so, we reduce recidivism. We make jails and prisons a safer and more recovery-oriented setting. We keep people from returning to jail and prison as they move along through the system to wherever they may be headed next. We mentioned the competency restoration wait list, where there are hundreds of Texans in jail right now waiting for access to mental health services. We need to be facilitating options that will be available to these individuals to restore their competency, because that's what they're in jail for, is waiting for competency restoration services. They're often waiting hundreds of days for access to these services, and the state hospital system is most commonly utilized for these services. But there are other methods that can be used as well, like outpatient competency restoration. So why shouldn't we have an outpatient competency restoration program available in every community across the state of Texas, rather than just relying on inpatient competency restoration even for relatively low-level offenses, including misdemeanors? That is an approach that doesn't make sense. Their outpatient competency restoration services can work for many different types of misdemeanor charges, as well as even some felonies can be addressed in outpatient setting. We need to be doing a better job in the juvenile justice system, which is not particularly trauma-informed. A lot of young people end up there who don't need to be there. And increasing our investment in mental health services in the state juvenile justice system, as well as local juvenile justice systems, will keep people from ending up back there. This is not, the juvenile justice system is not intended to be a long-term setting for most people. So by giving people access to mental health services, they're more likely to be able to move on to the community or some other form of care. And then a statewide Good Samaritan policy for people who are experiencing overdose that will save lives, that will facilitate recovery. And we've advocated for this before. Law enforcement officers should not be arresting people who are experiencing overdose, and people shouldn't have to be fearful that if they're experiencing an overdose and they call the cops, that they're going to get arrested for whatever drug possession offense they may be guilty of. This will save lives and help a lot of people. I mentioned the criminal justice system as it relates to capital punishment. Individuals with severe mental illness who had severe mental illness at the time of their offense should not receive the harshest punishment possible. Giving them the harshest possible punishment fails to recognize the reality that severe and persistent mental illness can compromise a person's ability to make rational decisions and understand the circumstances and practice, judgment. It's not a fair punishment. The punishment doesn't fit the crime. If a person is guilty of capital murder, they deserve to be punished for that. But capital punishment, just like we exempt juveniles and individuals with intellectual and developmental disabilities from capital punishment, we should also exempt individuals with severe mental illness. And we've advocated for this bill in past legislative sessions, and it has passed the House. Now we need the Senate to do the right thing and move this bill to the governor's desk. And then we can also be doing a lot more in post-booking jail diversion. So while we have a lot of opportunities to divert people from even entering the criminal justice system in the first place, there's a lot of pre-arrest diversion that can be done. There's diversion that can be done in the jail setting. But after a person is booked and they end up in front of a judge, we have programs like mental health courts, which are proven to reduce subsequent arrests and days of incarceration, specialized mental health treatment services for people who have been brought into the jail. This will cause fewer people to end up on the competency restoration wait list. It'll cause fewer people to receive long-term jail sentences for whatever crime they will have committed. It still holds people accountable, but a mental health court for a person with a mental health condition is generally better than just a general criminal court. We also should be doing a better job when it comes to providing housing services and other support services. It stands to reason that mental illness can contribute to the onset and chronicity of housing instability and homelessness. People who are just receiving an SSI check will often have a hard time covering rent and other basic necessities. And without additional support, individuals with mental illness may not be able to maintain various forms of stability. And, you know, access to housing services or the lack thereof is one of the, you know, primary reasons that we have such significant problems with homelessness in many communities across Texas, and so many of the individuals experiencing both temporary and chronic homelessness are impacted by mental illness, as the last bullet point indicates. Well, actually, the last bullet point expresses, you know, high unemployment rates, which is another issue that needs to be addressed. People need access to employment and a good job, which facilitates their recovery and helps them maintain or attain independence and helps them stay out of other settings such as the hospital system. So on housing and other support services, Texas should be increasing its investment in rental and utility assistance for people with mental illness. This will help them attain housing stability. We also need specialized housing for people who are leaving the hospital system or leaving the criminal justice system. You know, it could be said that leaving these settings is like walking off of a cliff. You either, you know, you're in the hospital system or the criminal justice system, and it's intensive, you know, support and supervision 24/7, and then you come out of that setting and, you know, the default option is a group home or a boarding home. And we need something in between. I mean, certainly permanent supportive housing is you know, a great need for individuals with serious mental illness, but something in between the hospital and a group home, or the hospital and some other form of permanent supportive housing is necessary. And this could take the form of step-down care. You might even have step-down housing right on the hospital grounds or right near the criminal justice system. And having such housing in place will reduce the recidivism rate of people going back into the hospital or back into the criminal justice system. It's a bridge to a more permanent housing solution. And the first item here, improving the home and community-based services program, it very much aligns with what I was just speaking to. We have an existing program in place in Texas for people who have been in the state hospital system for a long time, or who have been repeatedly arrested and placed in the criminal justice system. We need to better utilize that program, make it available to more people, and be holding the housing providers in that program accountable, because oftentimes they are funded through this program, but the services that they provide are inadequate. So we need to be funding better housing providers for, you know, as people are coming out of the hospital or the criminal justice system. So because the better the housing provider, the higher quality the services are, the less likely it is that a person will end up back in the hospital or criminal justice system. And then for people who are homeless, we need both permanent supportive housing, as I mentioned earlier. I mean, that is really, you know, the gold standard. That is what should be available for everyone who needs access to it. Just a roof over a person's head is not enough. You need built-in support services that are going to be available permanently. Mental illness is a chronic health condition, and many, many people impacted by it will experience the impacts of it for the rest of their lives. And so the supports that they receive in whatever housing program they're in should be available to them on a permanent basis, on site, and as part of their housing program, not as something that is separate and that they have to travel across town for. And then for people who are currently homeless, they need to be rapidly rehoused and as quickly as possible the longer they're out on the streets, the worse their outcomes are going to be, the more likely they are to end up in the criminal justice system or in the emergency room. And when it comes to other support services and unemployment support, big shout out to the San Antonio Clubhouse, a model for clubhouses around the state and around the world, as far as I'm concerned. San Antonio Clubhouse is a beacon of hope for so many people, and is a program that has influenced other clubhouses around the world, and what they offer is needed in every community. And if you're not familiar with San Antonio Clubhouse, check out what they have to offer, because what they're doing is improving people's quality of life. It's helping them access employment services, helping them access housing, helping address whatever need a person with serious mental illness may have. And more of these services are needed around the state. And that's why we've worked closely with San Antonio Clubhouse and other clubhouses in the state to increase the state's investment in the clubhouse model. And last category here are certain targeted populations. We wanted to make a section of our platform focus on populations that are badly underserved, that are in need of special attention. Those populations include new mothers or expecting mothers who are often impacted by postpartum depression. And postpartum depression is one of the primary reasons why Texas has such a high maternal mortality rate. We know, we've known for a while, but we know especially more in this time because of our nation's reckoning on racial injustice. We know that people of color experience worse mental health outcomes. They're more impacted by inequities and disparities in mental health care. So that population is in need of additional services and supports beyond the status quo. We know that poverty and economic uncertainty can impact people's mental health. In communities like San Antonio, where veterans and active duty service members and military families are so prominent in the community, we know that those populations experience higher rates of mental health issues, and they are in need of special attention and support. Also, LGBTQ plus individuals are disproportionately impacted by mental health issues, and individuals with intellectual and developmental disabilities are disproportionately impacted by mental illness as well. So what can we do? We can facilitate access to peer services to pregnant women and new mothers. And we can extend Medicaid coverage so that Medicaid, after a child is born, Medicaid doesn't shut off after 60 days. Medicaid should go for a year, especially in light of the fact that postpartum depression can last for much longer than 60 days after a child's birth. Medicaid coverage will save lives, will help a lot of new families with infants. So we've advocated for that before, and we'll continue to advocate for it again. When it comes to eliminating racial disparities, Texas should have initiatives that are targeted towards these disparities. We should have state agencies that recognize and account for the disparities, and that utilize that recognition to provide, particular attention to racial disparities and racial groups that are disproportionately impacted by certain health issues. So we should revive the Office of Minority Health Statistics. We should require medical and mental health professionals to receive implicit bias training. And we should develop incentives for mental health provider training programs to recruit and train providers from underrepresented communities of color. People will often want to receive services from someone who understands their cultural background, and ensuring that we have providers who look like the communities that they serve will facilitate better outcomes. When it comes to poverty and the impact of poverty on mental health and well-being, we know through research that when people lose their job or are experiencing poverty, it causes great concerns for their mental health. And that's why, during COVID-19, when we've had such a significant economic downturn, the suicide rate is increasing, and studies are showing that the suicide rate will be much higher in the future if we don't put policies in place to address this reality. So, there are a number of COVID-19 impacts to mental health, and one of those impacts is that economic uncertainty is bad for people's mental health. So we should be addressing that economic uncertainty by providing paid sick leave, by ensuring that recipients of unemployment benefits are receiving their unemployment benefits in a timely fashion and not having to call Texas Workforce Commission day after day in hopes of getting through to someone. We should be automatically renewing food stamp benefits, increasing benefit amounts. Those types of policy changes are things that we will likely support because those policy changes would benefit the mental health of many Texans. I mentioned the mental health of veterans. We need to continue our investment in mental health services for veterans. There are a couple of existing programs at Texas Veterans Commission, Health and Human Services Commission that are targeted towards veterans, veteran families, and active duty service members. Those programs need to remain in place. And post-traumatic stress disorder, as I mentioned earlier, should be a serious mental illness in the Texas Insurance Code. Another population that I mentioned earlier is the LGBTQ+ population, which has an especially high rate of suicide. Providers should not be allowed to practice conversion therapy. Trying to change a person's gender identity or sexual orientation dramatically increases the risk of suicide. And last legislative session, there was a bill to address this, and it did get a hearing, and we supported that bill. But we need that bill to move all the way through the legislature and arrive on the governor's desk because we are losing lives to conversion therapy in our state, and that is just not okay. There should also be incentives for medical and mental health professionals to receive LGBTQ+ informed training. As far as services for individuals with co-occurring intellectual and developmental disabilities, we need funding for adult protective services to address the backlog of abuse and neglect investigations for people who are institutionalized, including those who are institutionalized in state-supported living centers. This is much needed to help these individuals who are often abused and neglected. They suffer, their mental health is impacted by this, and timely investigations will help to get them access to the right care at the right time. And then there should be treatment standards for individuals with co-occurring mental health conditions and intellectual and developmental disabilities. There is not a body of knowledge that has been reflected in state law as far as what treatment should look like for this population. We know through research what works for individuals with these co-occurring conditions. Now we need to put that in state law. Let's act for mental health. The legislative session is right around the corner. And well, I'm really excited to work with you all to advance these mental health reforms. So thank you for all you do. And if there's time, I'd be happy to take any questions. If there's not time, please don't hesitate to reach out.
Thanks, Greg. A lot of wealth of information here. We are going to ask that questions be submitted through the chat, And we'll be collecting those and submitting those to Greg via email in the interest of time, because we do want to talk on NAMI Smarts, connections, and suicide prevention. So we'll turn it over to Carol Hollins. Carol, you're muted.
Okay.
There we go.
I am so sorry. Okay. Greg, thank you so much. That was an awesome presentation. I'm certain everyone in the audience today will certainly agree to that. You've provided a wealth of information for us to kind of ponder over. Again, Melanie mentioned, my name is Carol Hollins, and I'm a part of the NAMI San Antonio affiliate staff. And most of you in the audience are familiar with the various types of education classes that we offer, like family to family, basics, and peer-to-peer, and then all of the various support groups. But many of you are not aware that we do offer another course that's called NAMI Smarts for Advocacy. And in the interest of time, I think what I'm going to do is just read from my flyer for you, so that you know each and every one of us on this call today can make a difference by becoming more involved in advocacy. Grassroots advocacy is about using your voice to influence policymakers and make a difference. You can turn your passion and your lived experience into a positive voice for mental health with the NAMI Smarts training for advocacy. NAMI Smarts for Advocacy will enhance your advocacy skills and help you shape a powerful and personal story that will move policymakers. NAMI Smarts makes a difference because it gives you step-by-step tools, and you'll actually be given hands-on practice that you need so that you can feel very clear, confident, and ready to make a difference when you're advocating before policymakers. The title of the training again is called NAMI Smarts for Advocacy. This year, we're going to offer classes on Saturdays. The first one, November 21st, the next one, December 12th, and then again on January 3rd. And we're thinking that this is a very effective way to present these classes so that you can hopefully, be a part of all three, or if not, one or two of them as we lead up to the legislative session in 2021. Now on here, the flyer indicates that the time is to be determined on Saturday, so you will be provided an update on the actual hours, probably about 2.5 hours for each one of the sessions on Saturday. And we're looking at possibly 11 a.m. to maybe 1:30, something like that. Okay, the sessions are going to be offered on Zoom, online, and here's registration information. You would contact me at that email address, and they're the details that I need from you. But just to give you a little bit more about what to expect in the classes, for example, the very first class is going to teach you how to tell your story. When you go before policymakers and folks that are in the positions that we need to make sure that we share what it is that we would like for them to do. Okay, now see, elected officials are faced with a host of issues and interest groups. So this is going to be a way for you to develop a personal relationship by developing a well-crafted message that can make the difference in capturing their attention to support mental health issues. They don't often have a lot of time, to deal with each one of us individually. So we actually, in the course that teaches you how to tell your story, we give you great tips for telling your story. You'll even have an opportunity to listen to an example. We teach you what really makes a story work. You'll even have the opportunity to write your story and practice it in our session. That's kind of what you can expect in the very first module. Then the session in December, we're going to cover how to write emails, how to make phone calls. And there's really a very effective way to do that. We're going to talk about the importance of doing those two things, writing emails and making phone calls. We'll give you some great tips on how to do it. We'll even share examples again. And we're going to begin that session by reviewing why people who care about mental health should be writing emails, why you should be making phone calls to elected officials. And if you had already taken the first session in November, you're going to be able to tie in your story that you have developed. And you're going to recognize that it's going to end up being a pretty simple situation. The too much information is too much. So we teach you how to make certain that you're brief when you're doing this. And then in the January 23rd session, going to be very important because that's the one where we're going to actually help everyone prepare for Advocacy Day. Advocacy Day in Texas is normally held in the month of February. And Greg, you can correct me if that's going to be different this time. But in past years, we've had wonderful sessions where NAMI San Antonio has actually chartered a bus and loaded it up, and we all went to Austin on the Capitol steps and rallied, and then had time to go in and meet with the officials. Is that still a pretty good time frame, Greg?
Yeah, I was about to put in the chat. Actually, we're looking at having Advocacy Day on April 6th of 2021, and a save the date will go out shortly.
Okay, all righty. Thank you very much for that update. But anyway, on that last session, you're going to be taught some very, very important things about why you should advocate. Again, you're going to have an opportunity to tell your story. And I just cannot overemphasize how important the NAMI Smarts modules are, and we'd love to have you participate. So if you will make note of the registration information by email to me, you can in fact begin letting me know today that you're interested. And the reason I say that is because that will give us an idea of the total number of sessions that we may need to have. If we have a very good response, and now knowing that it's moved from February to April, we'll have more time to incorporate more training sessions if we need to. And with that, I'll toss it back to you, Mel.
All right. So we're going to now discuss NAMI connections briefly with Vernon Lister.
Thank you,
Vernon,
Mel.
make sure you're unmuted.
Thank you, Mel. This was a great session, Greg. Thank you so much. And thank you, Carol, for following up and having NAMI Smarts. This is going to be great. Listen, I want to tell y'all, I'll let y'all know about NAMI Connections Recovery Support Group. They are going on strong right now. We have a group. We had a group last night with essential workers. We had 3 nurses. We had a policeman. Just because they're professional doesn't mean they can't have a diagnosis and don't need that support. It is a wonderful program. People feel very relaxed and comfortable in sharing we want to expand it also. But let me tell you, we have an over 40s group on Saturdays. San Antonio Clubhouse has supported us immensely by having support groups every week. And then we have one for general mental health conditions. We have one for veterans. That is going very well. They're all going well. We have going to be starting the first and third Tuesday, starting now, co-occurring disorders, substance abuse. We have people from the specialty courts that have graduated, that are become peer support specialists, and they are leading these groups, along with a veteran who had substance abuse and is in recovery. These are great groups. I'm excited. We're starting college and university students support groups. And let me say, we're also starting or have NAMI on campus at UIW. We have an intern working with us, Valerie Sanderson, that is helping us have these support groups. We're reaching out to all the colleges and universities, sending them a letter out to the counseling department. So these are great groups. I don't want to take any more time. Want Greg to answer questions, but we're also very interested for the deaf, having a support group for them in sign language, and also one for LGBTQ. I've already gotten response on my phone about that. We will be starting these groups. So thank you very much, and please let everybody know about these support groups. Turn it over to you, Valerie. Over to you, Mel.
Thanks, Verna. There's a lot of change that's happened with NAMI Connections in such a short amount of time, and we really appreciate all the work that's been done in this area to reach the unreached in the community. We've had a fantastic program today, but we would be remiss if we didn't recognize September being Suicide Prevention Month. And so we're going to have Terry Mabrito give us a few thoughts on that and close us out.
Hey, everybody, can you hear me?
Yes.
Yes.
Yeah, I'm going to try to, I may or may not be able to share my screen because it doesn't seem to be, let me see if I can find it because I opened it, but now it's not showing me. But I guess the main thing, if I can't show this, oh wait, I think I got it. Hang on. I'm learning. All right, so maybe you can hopefully see this slide. I wanted everyone to know that, will it open? It's trying to. Maybe not.
We can see your screen, Terry.
Oh, that's interesting. There's a timing on that that I have no idea where that came from. That is quite interesting. It's coming. So anyway, you need to know that during COVID-19, CHCS does have some crisis counseling funded program right now. And I thought that was important for folks to know because a lot of folks do not know about this number. So if folks are experiencing difficulties, they can call the number at the top there, 210-540-7410 for NAMI for help around issues that they might be experiencing during COVID-19. Then, of course, you all know the typical, CHCS crisis line. That's our local line on the screen, and certainly the suicide prevention lifeline number 1-800-273-TALK. If you want to, if you're not comfortable talking, you can text NAMI to 741-741 and be connected to a trained crisis counselor. We also have lots of course, resources on NAMI.org, and there is a crisis guide that's in English and in Spanish, and we want you to know about that. You can help us by just sharing and, using our hashtags, hashtag suicide prevention or stigma free. And then let me see if I can go to the next slide, because boy, this is really not how I'm used to seeing it at all. Let me see if I can, here we go. So can you all see that at all? Okay, so I want to give a call to action. So not only do we want to to pay attention to all the points that Greg brought us and that Carol is sharing, that we can, get involved by getting trained in NAMI Smarts, but we can also participate with NAMI National for at the congressional level. So I really have a call to action that I want everybody to take note of right now, and that is to move forward with changing that long suicide prevention lifeline number to 988. And I won't talk more about it. It's all right there. You can participate right away by just filling out the forms, and you'll see you can find it on the NAMI National website. It's super easy to do. And those are great ways to just fill out a quick form and, get connected to issues, and then it'll tell you how you can take action. So I want you to do that. It's Suicide Prevention Month, and we need people to be able to have a quick access to a crisis counselor, and that is going to be so much easier with a short 988 number. It's been through the House already. We just need to push it forward. The FCC has already designated that number, so we just need that final push. So I invite you to be active. Act now on 988, and I think that's all I've got. Do we have anything else, Carol or Mel? You're muted, Carol.
Terry, I think that's it. Other than thanking everyone for participating today, we need you. We understand how great the cause is, so we all need to just continue to move forward and do what we can, especially by involving ourselves in advocacy. There's so many different things that can be done. Thank you so much for being here today, and don't forget to put your questions for Greg in the chat box.